Welcome to my A&E talk. Here we discuss everything that is relevant to current A&E practice, and I'm Noel, A&E registrar working at NHS.
Welcome to A&E talk, and today we're going to discuss about a paper, and this is something I found in the Emergency Medical Journal, and the paper is called Pain Induced by Investigations and Procedures Commonly Administered to Older Adults in Emergency Department. It is a prospective cohort study, and a disclaimer, this is by no means a critical appraisal paper. This is just basically, I found something interesting, so I thought we'll discuss and take some learning points out of it. So I'm just going to run through this paper quickly and just take the important bits out of it and dive into the meat of the subject over here. Observational cohort study was done in 2 EDs in Quebec, Canada between June 2018 and December 2019. This was done on hemodynamically stable older adults, that is 65 and above. So what they were trying to find out is trying to find simple ED interventions and the pain associated with it. So they used a simple 11-point numerous rating scale, which is 0 to 10, 0 being the no pain and 10 being severe pain, everything in between. And this is a very common pain scale that's been used all around the world, including the ED I work in. So what they're trying to do is assess the older adults who had at least 2 interventions or more in ED. That includes like getting an IV cannulas or urinary catheters or getting a blood taken out. So any 2 interventions, and then rate the pain accordingly to the intervention. So they had a total of 318 patients, and the mean age was around 77 plus or minus 8, and 54.4% were female. Let's go through the interventions that they have looked for. So the first thing we're looking at is blood sampling. So out of the 318 patients, 231 patients had blood taken out, and the 231 patients gave a pain score of 1. So that falls under low threshold of pain. The other one is IV catheters. So that is 240 patients had an IV cannula placed in, and they have rated the pain at 2, once again falling into the low category. Urinary catheters, that is 22 patients who had urinary catheters, have reported pain of 4.5. So now we are creeping into moderate pain. And cervical collar, 50 patients had cervical collar, and they have rated their pain at 5, once again falling in the moderate section of the pain scale. And finally, looking at the immobilization mattress, like the trauma mattress, and they have also rated that at 5. So the last 3 I mentioned have fallen in moderate category of pain. And as you can see from this table, they also checked out all the imagings that you commonly get in ED, and all of them has been rated as no pain. Pain is the most common symptom reported by older patients in ED. Well, as you all have worked in ED, you know that is true. You get patients who comes with quite a lot of pain as their primary symptoms, or symptoms that is associated with some other clinical features they're present with. Cognitive impairment can limit the ability to communicate their pain in certain older adults, which is very true. And that's why, as a golden rule, we treat those patients assuming that they have pain according to the clinical feature they're presenting. Let's say they had a long lie on the floor, they had a fall, but even in ED they're not communicating or showing or expressing the pain. We assume they are in pain, and we treat them. We give them the adequate painkillers, which is a golden rule. There are other factors can also affect in an older adult communicating the pain to us, is through communication barriers, age-related hearing loss, so on and so forth. Pain is frequently overlooked and underestimated, is what this study points out, which is very unfortunate to hear, but something we can't deny. Older patients regularly undergo interventions in ED, but the pain due to that is unknown. that is also could be very true. Some people are forthcoming in telling their pain. Some people just bear it. Some people have a better pain threshold. And again, as the previous points that I've said, some people are just not able to communicate. Pain is associated with prolonged ED stay and delirium. That is a very valid point. So when a patient is in a lot of pain, well, obviously you can't just send the patient out of ED or move them out if they are still in pain, especially when they come in with their primary symptoms is pain. So that can prolong the ED stay, and it can lead to delirious effect, which both things we just don't want to happen, especially in an older adult. And this study also says older adults are less likely to receive a painkiller compared to a younger patient, which is very sad to see. Why? Well, I'm trying to think about this point, the only reason I can come up is why. Is it because they are scared to prescribe more painkillers to older adults because they're worried about the side effects? Or they feel like, they might end up, push the patient to the other side if you end up giving, a stronger opioids or something you just an effect you don't expect or you don't want to happen. So maybe they're being conservative and pull themselves back when they're trying to prescribe. Maybe that's the only reasoning I'm able to think of. Most common ED investigations and procedures were met with no or low level pain in ED, which, as the study points out, is the most common things is people getting their bloods taken out of ED, which is very common. Getting an IV cannula in is again very common, which I always tell to my junior is an IV cannula in ED is like a lifeline. As you know, most if not all emergency drugs goes through IV lines, so in case of an emergency. So yeah, these two things are very commonly happens to almost all patients in ED, and they are met with low pain scoring, which is good to know. But except for the cervical collars, the urinary catheterization and the immobilization mattress, which is very valid, none of those three are pleasant or comfortable. I have a personal story of my own from the cervical collar. So when we were having a bachelor party trip with my friends, and I was in my passenger seat with my seatbelt on, thankfully, and we had a bit of an accident. Car just rolled over 3 times and they had to pluck us all out from the car. And I vividly remember being put on a rigid cervical collar and put on a rigid trauma board for a transport. I can't remember during the transport or in ED the trauma board or the trauma mattress causing any trouble, but I do remember the cervical collar. It felt like I was slowly getting strangulated. That I remember. So that is something I can watch for. So yeah, cervical collar, immobilization mattress, they're all just not pleasant. The study also says that they had a previous research in children who underwent immobilization in suspected cervical spine fractures, and they also reported pain throughout the pediatric age group. So the bottom line we can take out of this is, well, it just causes pain for all age group. And there's another very interesting study that has been quoted as a reference in this paper that shows that only 11% of professional rescue personnel and emergency practitioners could effectively fit a cervical collar without error, despite training and subject to confidence. Now, 11%, that's a very low number, and I'm surprised to see that. This study also points out that the application of a rigid collar in older adults is controversial, which I tend to agree with. So there are a lot of papers that shows, especially another paper in the same emergency medical journal that has also been published on similar topic, has shown lack of any high-level evidence of pre-hospital C-spine immobilization actually helping the patient. And a rigid collar can actually lead to inappropriate cervical hyperextension, and can actually increase risk of fracture, displacement, leading to worse neurological symptoms on patients. So they have underlying spinal problems. They have underlying, let's say, arthritis, spondylitis, any number of things that could happen, and just forcing them to be put on a rigid collar could actually cause more harm than any benefit. So there's multiple papers that actually has shown that the rigid collars are of not much of any benefit, and then certain things, the historical thing of protecting the C-spine has been challenged because of these findings. The important point is obviously try to remove that collar and get them off the trauma mattress as fast as possible. Well, that goes without saying, but sometimes they tend to get prolonged or delayed because the imaging is not been reported yet. We are waiting for the imaging to be done. So there are a lot of other multiple factors play into it that could actually prolong an older adult to be in that collar or on that mattress just for too much of time. So that we need to be mindful of. So we need to mobilize them quicker for the imaging if that needs to be done, and trying to chase that up or try to get that report done on that cervical spine, if that can help them to get them off from those awful two things, then we must be on that immediately. Urinary catheters are associated with moderate pain in 40% of patients and severe pain in 23% of the patients. Well, again, a urinary catheter is not a pleasant thing for a patient to go through. Fortunately, I've never really had a urinary catheter go through me, so I can't imagine the discomfort or the pain the patient goes through. But then that is something we know that none of the patients are just looking forward to it. We know patients have discomfort. We know patients have pain when we do that procedure on patients. Even though these things, the cervical collar or putting them on a trauma mattress, or getting a urinary catheter done for whatever reason, whatever the clinical presentation the patients have come with, we know these things are needed. These are things we do for the patient because we're trying to help them. We are trying to do these interventions to help the patient. But then we should also be mindful that these interventions that we're trying to do to help the patient causes pain, as this study shows. I know in the back of our mind, we all know these things causes pain. Of course, this study has its own limitations, such as convenient sample, population not recruited in a continuous manner, finding in older adults with cognitive impairment is unknown, presence of other comorbid medical conditions were never recorded, things like osteoarthritis or anything that could have influenced probably a certain group of people who, when they were put on the cervical collar or in the mattress, could have had more pain than the other patients. We didn't know. 50% of the patients in the study actually received some kind of a painkiller in ED, so maybe that could have influenced in this pain scale. So these are some limitations that I'm able to pick up, but there are plenty more in the paper. Take-home points. In the back of the mind, we should always remember the interventions we are doing in ED to help the patients can also cause pain. So be mindful of it and try to optimize it by giving them adequate painkillers or trying to do things that could maybe help them. Well, we know we use the cold spray and the Amotop gel for pediatric age group, but I've actually used cold spray on even older adults and found it to be helpful. Very small portion of people have used that on, and I found that to be helpful. Maybe something, so we can optimize certain things to help them in case, if let's say if the patient is needed repeated puncture just because of their veins are hard to find or it's very hard to bleed them. So the other way we all most commonly use is an ultrasound in ED. We can use an ultrasound to find that deep veins or the hard to find veins to cannulate or to get the bloods out. So we can optimize things to help them. And obviously, the most important point is to remember about the cognitive impairment on patients and that they also will be in pain even though they're not able to communicate. So we need to be super mindful of these things and treat them. Treat them as if they're in pain, as if they're screaming in pain, and give them adequate painkillers. And not to hold back, but to give appropriate dosage according to the patients, their renal and hepatic clearance, and give them the doses we think is adequate. So these are the points that I was able to get out of this paper, and I've found this paper to be interesting, and that is the reason I picked this up for this video. And thank you for joining with me to this A&E talk.